So today I'm going to be talking about creating vicarious trauma-informed environments or research environments. So the research element is intentionally put into brackets because although I'm going to talk about a research example in terms of applying the principles of vicarious trauma-informed practice, what I would like anyone who's joined or listening to the recording to take away is how this might be applicable to all organisations or environments that are trauma facing, not just research environments. So what are the aims of today's session? So one of the main things that I want to do is to normalise vicarious trauma. I'm going to talk about vicarious trauma in the research context and use an example from practice. I'm going to talk about how we notice vicarious resilience, and I'll be providing you with some recommendations for creating a vicarious trauma-informed research environment. And as I said, thinking about how those can be applied more broadly to all environments. There should be time for questions at the end. I've also got a list of other resources and training for anyone who's interested in learning more about trauma-informed practice more broadly. So I'll start by thinking about normalising experiences of vicarious trauma. And I'm going to start with a quote from a book that was focused specifically on vicarious trauma in the legal profession. And so these two authors talk about how being able to describe the fact of our exposure to trauma should not be controversial. It is not a matter of who is and isn't affected, rather it's a fact of life. So really the argument here is that when you work with trauma, when you're exposed to trauma, whether it be through direct delivery of services, whether it be through traumatic material, any kind of work that involves exposure to trauma, it's not a question of if you're affected, it's a question of when you're affected and to what degree you're affected by somebody else's trauma. So this is a really important progression in the literature around vicarious trauma. And thinking about vicarious trauma as a normal response to exposure to traumatic material becomes really important when we think about normalising experiences, destigmatising experiences of vicarious trauma, and encouraging people to seek support, whether it be from their peers, their colleagues, whether it be from their line managers, whether it be more structured professional expert support. One of the biggest mitigating factors for the impact of vicarious trauma is around our capacity to talk about it openly and to break cultures of silence that often exist, particularly in professions like healthcare, for example, where there's a sense of identity as a healthcare professional that's built up around being able to cope with high levels of trauma. It becomes part of the job. You just need to get on with it. It's a sign of strength and stoicism not to talk about vicarious trauma. And conversely, if you are experiencing vicarious trauma, and particularly if you're talking about it, then that's a sign of weakness. So this is a really important starting point. And if you take nothing else away from today's session, vicarious trauma is about when we experience vicarious trauma, not if. So what are we actually talking about when we talk about vicarious trauma? And you may have heard of different terms. You may have heard it referred to as secondary trauma as well as vicarious trauma. I'm going to use a definition here from the British Medical Association, who talks about vicarious trauma is a process of change resulting from empathic engagement with trauma survivors. Anyone who engages empathically with survivors of traumatic incidents and material relating to their trauma is potentially affected. And from a research perspective, that idea of it extending to material becomes really important. So we're not just talking about those frontline service providers. We're not even just talking about the researcher who's undertaking interviews with those who've experienced trauma. We're talking about anyone who is exposed to traumatic material is potentially affected. When we talk about the impact of vicarious trauma, what we are talking about is somebody who is exposed to trauma or traumatic material, and in doing so, it shatters their own assumptions of safety in the world around them. And they are then forced to recreate a view of the world which takes into account the fact that it's not necessarily safe. So I'll talk a little bit about some of the indicators of vicarious trauma, and particularly in the context of road traffic collisions, where we might see that most starkly show up for those who are exposed in that field. So some of our indicators of vicarious trauma do overlap with other aspects of workplace stress, such as burnout or compassion fatigue, but there are significant differences, and I'll talk a little bit about that. So being preoccupied with thoughts of the case outside of a work situation, so thinking about someone's stories and experiences. So for anyone who's been exposed to traumatic experiences, whether it be first-hand accounts or whether it be through reading traumatic material, you might notice that in the hours and even the days that follow exposure to trauma, you're thinking quite a lot about what you've seen or heard or you've read about. And then you might also notice that after a couple of days, it starts to lessen in its degree of intensity and you start to think about it less. For some people, that stays with them. So those thoughts about somebody's trauma might stay with them, say, for weeks or even months that follow. You may also experience lingering feelings of anger, rage, and sadness about someone's situation. You might notice that you become overly involved emotionally, particularly if you're a frontline practitioner. So this often shows up for practitioners in the form of doing more for somebody than perhaps you would do for another case. It's also experiencing bystander guilt, shame, and feelings of self-doubt. An over-identification with the person. So what if it were me? It could have been me. So sometimes those barriers that we put in place when we work with someone who's experienced trauma, we tend to automatically put up a bit of a barrier between ourselves and them. And that's intentional in order to protect ourselves from becoming overwhelmed with someone's trauma. So it's not necessarily a bad thing to do. It's a coping strategy for ourselves. And sometimes those barriers get permeated, and that could be permeated for a whole number of different reasons. For example, if you are supporting a bereaved parent whose child is the same age as your own child, if there are similar names in common, if somebody reminds you of a family member, are just some examples. We can also see loss of hope, pessimism, cynicism, and a loss of motivation. Again, that's got a lot of overlaps with things like burnout as well. We can also see fear and anxiety in relation to or avoidance of situations which remind you of the person's experience of trauma. And that most commonly shows up in this field around a fear of driving, a fear of being a passenger, a fear of somebody you love driving or being a passenger, a fear of cycling, or even anxiety around being a pedestrian. We also see distancing, numbing, and detachment, and staying busy and avoidance of listening to someone's story of traumatic experiences. So this very much goes in contrast to this idea of becoming over-involved emotionally. We sometimes may see the opposite end of that spectrum, where somebody is perhaps shutting someone down and saying, I don't need to hear about that. I don't need to know about that. And that might be because they are working really hard to protect themselves from that exposure to trauma because they're experiencing that trauma vicariously. And we may also see difficulties in maintaining professional boundaries with the person, somebody overextending themselves and trying to do more than is in their role to help them. All of these are indicators of vicarious trauma that are shared without judgment. So we will all, particularly when we work in frontline services, we will all be able to cite examples where we have experienced many or at least all of these things in our work. And again, thinking about that being a normal response to experiences and exposure to trauma and traumatic material. I want to link this to the idea of traumatized systems. So one thing that's really important to remember in the context of vicarious trauma is it's not happening in a vacuum. Our exposure to vicarious trauma is happening within the system in which we're working, particularly if we're working in a research role where we're looking at experiences of distress or difficulty or adversity, or where we're working in an environment or an organisation that's trauma focused. So just like people, organisations are alive, they're always developing and adapting, and they are equally vulnerable to stress. So we have loss, dissociation, and toxic stress can spread, sorry, can spread like contagion throughout an organisation. And when this happens, it can be traumatised and distressed, which can result in practices that induce rather than reduce trauma, resulting in that trauma-driven culture. So what we know is that sometimes the systems in which people are doing their work can act as a really significant source of support and protection and mitigate the effects of trauma. But equally, the system in which somebody works, if the system is traumatized and that's not being supported and addressed and recognized within the system, it can actually induce more trauma. So what we might find is that those experiences of vicarious trauma are actually compounded and exacerbated as a result of the system in which that trauma is taking place. I just want to talk a little bit about trauma exposure and its impact on teams and culture within an organisation. And again, this is without judgment. I'm yet to work with an organisation that's trauma facing that doesn't have some, if not all, of these characteristics. There is a lovely quote which talks about working with trauma and expecting not to be traumatized is like walking through water and expecting not to get wet. It is a simple fact of life. But where we might see trauma in teams and culture is we may see that team members are operating in predominantly reactive or crisis-driven ways. They might be disconnected from their purpose, their values, or mission of the work, experiencing a loss of meaning. There might be some quite polarized thinking. So, for example, there's the us and them dynamics, cultures of blame, or organizational silos. They might have reduced capacity for reflection, curiosity, and constructive challenge. They may be experiencing limited trust or even a loss of trust between individuals, teams, organizations, and stakeholders. Feel constantly busy with little space for thinking, learning, or processing what's happening. Respond defensively to scrutiny, criticism, or challenge. Demonstrate heightened vigilance and anticipation of risk, error, or reputational damage. They might experience increasing levels of stress, fatigue, and emotional exhaustion. Have feelings of uncertainty, confusion, or lack of direction, difficulties regulating emotions during challenging discussions or high-profile events, experience a sense of organisational chaos or being overwhelmed by competing demands, feel stuck, frustrated, unable to influence outcomes, notice an increased rigidity in processes, decision-making, approaches to risk management, including this idea of perfectionism, experience the cumulative effect of repeated exposure to distressing evidence, testimony, or human suffering, feel helplessness when confronted with the scale or complexity of systemic issues, experience fragmentation across teams, priorities, or organisational objectives, experience a loss of shared purpose, connection, or capacity for collaboration. For anyone who works in the NHS, then I would say that the NHS in its current state, if we think about the NHS as a whole organisation, I think we would all agree that we can see many of these features within our healthcare and certainly our social care settings as well. And so this is why it becomes really important to think about vicarious trauma as a systemic issue. So what we need to think about is not just somebody's exposure to client-related trauma, but we also need to think about the system in which that exposure is occurring. So there's a lovely piece of research which talks about how the system influences vicarious trauma, both in terms of compounding experiences of vicarious trauma, but also mitigating its effect. And some of the contributing factors that were found to mitigate and also to exacerbate were around that organisational culture, the variability of the workload. So what is somebody doing? Are they constantly exposed to high levels of trauma, or is there variation within the work that they do? What are the conditions of the work environment? So this could be things like what flexibility is there in place? What workplace adjustments are there? Is there capacity for somebody to work part-time, to work condensed hours, to finish early, to take a lunch break? What's their access to professional development? So just thinking about what support and opportunities is somebody given to develop themselves, and also what's the provision of quality supervision, and that can range from professional or expert supervision, which we might see in a healthcare context, right through to has somebody got access to their line manager? For me, what's really significant about this is nowhere is it mentioning access to professional support. And that is a really important reminder that actually the system has a huge amount of responsibility for supporting people and for mitigating the effects of vicarious trauma. So, of course, access to psychological support, professional support, whether it be counselling, psychotherapy, coaching, occupational health, all of that is extremely important when somebody needs that individual level of support. But I don't want to get caught up in that, because actually what the research is telling us time and time again is that if we can get the conditions right in which somebody is working, then a lot of that support can come from within the system itself. So I'm going to talk a little bit about how we address vicarious trauma in the research context, and I'm going to include an example from practice, and I'm going to talk about one of the studies that we're currently working on within Impact, and the steps and principles that we're applying to mitigate the effects of vicarious trauma, but perhaps more importantly, to enable it to be acknowledged and for early recognition and support to be put in place. So this refers to a post-mortem review programme, which is intended to strengthen the road injury chain of survival. So the study will use information from post-mortem examinations of people who have died in road crashes to understand which injuries were so severe that survival wasn't possible, even with the best possible care, which deaths might have been prevented if emergency services had arrived sooner or different care had been provided, and where improvements could have been made to how we respond to crashes. So things like calling for help, freeing people from vehicles, providing medical treatment. And the idea is that a team of senior clinicians experienced in emergency medicine and trauma care will review each case. They're going to use a structured approach to assess whether or not the death was preventable, and if so, what could have been done differently. So on the one hand, our starting point is that we're working with reviewers who are already exposed to high levels of trauma. So on the one hand, our argument is that they should be used to having exposure to high levels of trauma. However, what we also know is that this is different to their day-to-day role. And for some people, being exposed to trauma differently can also have an impact on their experiences of vicarious trauma. So if I talk about my own practice, I notice for myself that if I am working with a bereaved family in a support perspective, where I have a very clear role and a very clear meaning attached to that role in the sense of providing them with support, I can tolerate high levels of exposure to trauma. However, if I sit at a conference and somebody shares a traumatic story, it often has a much higher impact on me, because I experience a sense of helplessness because I can't actively do something in response to that trauma. So it's being aware that people experience trauma very differently depending on their background, their experience, their training, what their role is, and most importantly, the meaning that they attribute to the work that they do. So to address vicarious trauma, there's a few things that we're building into the process. So the first thing is that clinical reviewers will be required to attend a workshop on vicarious trauma. And this is a really important starting point for any organisation that's thinking about how can they establish a vicarious trauma-informed approach to the organisation. The first thing is always to provide information and help people understand what we actually mean by vicarious trauma. So doing that really important work about normalising, promoting understanding, exploring strategies for coping and support. And this for us will also be an opportunity for reviewers to consider how they might apply learning from the reviewer role to their clinical practice. So again, thinking about that idea of meaning. So why is somebody being exposed to this? What is the meaning of their exposure? Will often act as a protective factor for somebody and mitigate the effects of that exposure. One of the first things that we will be doing is asking our reviewers to review in pairs so that they have immediate access to peer support. And we'll also be looking to recruit them within their pairs so that they get to self-select who they work with. And we anticipate that they will choose people that they already know and trust and have a degree of a sense of safety with. In addition, a third reviewer will then be used in situations where a consensus between the reviewers can't be reached. And so as part of that process, the third reviewer will also be explaining their decision-making processes and seeking feedback from the reviewers so that to make sure that their views are heard and clearly understood and documented. So what we're doing there is really making sure that we build in another option for additional support. And again, what we also know increases frustration and increases the level of risk to vicarious trauma is when team members feel that their voices aren't being heard and that their experiences aren't being valued and validated. We're going to limit the number of cases for each reviewer to 10. And reviewers are going to be provided with access to structured psychological support via the wider organisation's employee assistance programme. Will enable reviewers to withdraw from the study without the requirement for an explanation or a period of notice. So this kind of no questions asked approach. And we will also be inviting reviewers to reflect on their experiences of the role at the end of the process and contribute to learning. That's not a mandated requirement, and what we're not asking reviewers to do is we are not asking them to engage in access to psychological support as a mandated requirement, and that's intentional because we want to assume our starting point in trauma-informed practice is to always assume that somebody has the capacity to cope, and we want to recognise resilience and build on that coping and that resilience. And so that's for one of the reasons why we frame this as being about learning and understanding people's experiences rather than suggesting that they need support or pathologizing what are essentially normal responses to high levels of exposure to trauma. So our key principles that we'll be applying are that normalizing, anticipating experiences of vicarious trauma. So again, shifting from if you experience vicarious trauma to shaping the conversation so it's around when you experience vicarious trauma, what do you need, what do you want? Increasing access to peer support and building this into the review process. Providing choices in relation to support, so offering peer support, managerial and professional structured support. Making it as easy as possible to withdraw from the study. Really promoting and encouraging meaning making. Why is the research important? How else can this knowledge benefit reviewers in their clinical practice? And helping to bridge the gap between what reviewers might be learning and encouraging them to then identify very clearly in concrete terms what they're learning and what that might mean for their clinical practice and also for the clinical practice of those around them. Promoting the wider benefit of participation, so thinking about how that knowledge from this can go back into the clinical environment, both in terms of what they're learning as part of the research, but also what they're learning within that initial workshop around vicarious trauma. So is there something that they're going to learn about vicarious trauma that they can then take back into their own work environments as well? And seeking feedback to inform research practice for when we plan for our child postmortem study, which will follow our adult postmortem study. So what are some of the recommendations? So what we're looking to do is to work to actively reduce the effect of vicarious trauma, recognising we can't get rid of it altogether, but what can we do to reduce the impact of it or to enable that early recognition? And so we start with our training and education to build that awareness, strengthen coping strategies and develop that capacity for peer support by developing skills in trauma-informed interventions. We want to make sure that we have access to timely and appropriate support. And we also want to make sure that we're not prescriptive about what that support looks like. So it will include structured psychological and psychotherapeutic interventions, but it will also be about offering a choice to somebody about whether or not they access trauma-informed peer and managerial support instead. And it's also about having targeted initiatives to identify and address areas of research practice where exposure to traumatic material is heightened. So our core principles for creating a vicarious trauma-informed framework would be about that psychological safety. So team members have the right to work in an environment where emotional and psychological well-being is protected and prioritised. that awareness and normalisation, vicarious trauma needs to be recognised as a normal and understandable response to exposure to traumatic material, rather than it being as an individual problem. So what we want to do is to really avoid pathologising those normal responses to trauma. It's about choice and agency. It's about helping people make individual, informed decisions about what their level of exposure is and participation, and making sure that they have choices around support. It's about that shared responsibility. So responsibility for managing vicarious trauma doesn't just sit at the individual level, it's also at leadership level and the whole organisational level. And it's thinking about ethical integrity. And so when we talk about ethical integrity in terms of research excellence in particular, it's about taking care of all of those involved in the work, not just focusing on the quality of the outputs that are produced. So how can we create a whole organisational commitment? That acknowledgement, again, it's an occupational risk. It's about embedding trauma-informed principles right from the study design through to how it's governed and then how it's eventually delivered. It's about making sure that there's access to a range of support, taking into account individual preferences and choices. It's about giving access to structured, independent, confidential psychological support. It's about making sure that we allocate enough time and funding and leadership attention to the well-being of the team. And it's also about reviewing and improving practices in response to feedback and also in response to emerging evidence as we go. So it's not about saying that we will ever get this completely right. It's becoming trauma-informed, and in particular becoming vicariously trauma-informed is an ongoing process that's never going to be quite complete. So what we want from leadership and governance, we want our leaders and managers to model open, non-stigmatizing conversations about well-being, to make sure that vicarious trauma is considered in ethics applications and risk assessments, to be monitoring things like workload, exposure levels, and the cumulative impacts of the work, to support flexibility in roles, timelines, and methods, to intervene early when concerns about well-being are identified, and to ensure the potential risk of vicarious trauma is really discussed right from the outset of recruiting and selecting new team members. What we're looking to do, if we think about it in research terms, is that informed consent. We want to make sure that potential team members and employees are aware that they may be exposed to traumatic material, and to encourage them at the interview stage to be thinking about what support they might need, whether or not that's okay for them, and for them to have a real awareness as they go into that role, what that might look and feel like. So in terms of thinking about study design and planning, research projects should be incorporating vicarious trauma considerations at the very outset. So it's about assessing potential exposure to traumatic material at the planning stage. So thinking about the nature and levels of exposure, and thinking about all of the team members who may be exposed to traumatic material, not just the obvious ones, and what's the extent of their required engagement. We want to embed strategies to manage and mitigate exposure. So working in things like pairs or small teams, implementing regular check-in processes, protected breaks and recovery time, opportunities for variation in workload and tasks. That becomes really important, particularly when you're working in trauma-facing roles, where it's perhaps not quite as easy within your everyday working life to build in that variability. So that's where the workplace and the system around you might need to be more proactive in building in more opportunities for variability. We also want to do things and introduce processes like categorizing traumatic material using caution markers with advanced information about the nature of the content in emails and document to prepare somebody and also to offer informed choice. So what we're not necessarily doing is saying that this is traumatic or distressing material, but we want to give a caution and make somebody aware that there could be potentially traumatic material, so that somebody is prepared right from the outset as to what that might look like. What we also know is that one of the biggest mitigations and protections for vicarious trauma is that preparation. So even though it doesn't change what somebody's exposed to, knowing what they might be exposed to allows the person to build in those protections, and that to build up that psychological resilience from the outset. There's nothing more risky than when somebody is caught off guard or by surprise by their exposure. We want to establish some really clear pathways for accessing support, and we want to really make sure that a range of support is available so that we're not just pushing somebody towards an employee assistance programme. Unfortunately, when somebody discloses a difficulty, such as vicarious trauma, when we signpost them to counselling or to the employee assistance programme, unfortunately what they hear is that this is their problem, not an organisational or a systemic problem. And that can often lead to them feeling more isolated. So whilst we would of course offer that individual level of support, it's also about offering a full range of support to somebody as well. And we want to make sure that we've got appropriate resources by budgeting for training, supervision and access to support. And of course, to avoid unnecessary or prolonged exposure to traumatic material wherever reasonable alternatives exist as well. So we don't just want to be exposing people to vicarious trauma because that's the easiest thing to do in terms of getting a task completed. We want to always be thinking about where's the flexibility, what's the alternatives there. So support should be accessible, so clear, visible, easy to access, and information about sources of support should be made available upon induction to the organisation. Wherever possible, support should be independent, so it should be provided by professionals not involved in study delivery or not or the option to have it provided by those without line management or supervisory responsibilities. It should be responsive, so it should be informed by what the person feels that they need rather than offering a kind of one-size-fits-all support. And that means that then support can range from that peer and line management support right through to structured psychotherapeutic interventions provided by a mental health professional. One of the best kind of forms of support that I've actually seen in practice, which I would say is one of the most trauma-informed approaches, is a piece of work done by a police force for a road policing team. And so part of their support package after their officers were exposed to a fatal road traffic collision was to hold what they were terming a debrief meeting afterwards, and then to give all of the team members a Greggs voucher so that it would encourage them to go for breakfast together after a shift. And have a cup of coffee together. And actually that's an incredibly trauma-informed approach which mobilises that peer support, but also acknowledges that people have a range of different ways of coping and doesn't move in to kind of pathologise those normal responses, but instead looks to support those social support networks that already exist within the organisation. And ultimately, it's about confidentiality, so staff should be provided with access to support that protects their right to privacy. So what about our culture and everyday practice? So we need to think about language that avoids minimising distress. So rather than thinking about it, this is part of the job, it's the acknowledgement that yes, it's part of the job, but it also has an impact. Just because it's part of the job, it doesn't mean that we don't get to be affected by it. We need to openly acknowledge and name experiences of vicarious trauma. We need that permission to pause and step back or decline tasks when needed, and to foster a culture where that's enabled and allowed and encouraged and praised. We want respect for different responses to the same material. That becomes really important to do that work around destigmatizing. And we want the encouragement of collective care and mutual responsibility. So vicarious trauma is never an individual problem. It is a systemic issue, not an individual issue. The support element might need to be individualised for somebody, but it's never an individual problem. And we want to have regular check-ins embedded into our team routines. We want to seek feedback on well-being and support. We want to include the perspectives of team members from a variety of different roles to make sure that those practices around vicarious trauma and how we mitigate the effects are inclusive and that they account for the differences in professional backgrounds and responsibilities. And I think certainly for the impact team, that's really important when we have researchers working alongside healthcare practitioners whose thresholds for trauma, whose past experiences of trauma may look very different. We want to be continually updating and reviewing policies in line with learning and best practice. And we also have a responsibility, given the level of trauma and traumatic material that our team are exposed to, we have a real responsibility to share what we're learning and what we're noticing with other organisations and with wider academic and clinical communities in which we operate as well, so that we can keep furthering the agenda and the knowledge base around vicarious trauma. And just as I finish, I also want to talk a little bit about vicarious resilience, because this is an emerging term within the literature, and it's really important when we think about a trauma-informed approach that we don't miss some of the benefits of our exposure to trauma and to traumatic material. So this is an AI-generated definition via Google. So when we talk about vicarious resilience, this refers to the positive effects that helpers or researchers or practitioners, whoever you might be, experience by witnessing the resilience of those they help, building their capacity to respond to adversity. It's the counterbalance to the negative effects of trauma work, focusing on the positive impact of exposure to a client's resilience. All of us who work with trauma, regardless of how we work with trauma, or the level of trauma that we're exposed to, all of us know that it's a privilege to be exposed to somebody's experiences of trauma. They are sharing a part of themselves that few other people are getting to see or to bear witness to. And so I want to think about the work that we're doing in terms of the concept of privilege. So what is our definition of privilege? Privilege can mean a special right available only to a particular person or group, or a benefit enjoyed only by a person beyond the advantages of most. And so when we do this work, it's really important to think about the terms vicarious resilience and what privilege is afforded to us when we bear witness to trauma and when we bear witness to traumatic material, is we are getting to see something beyond what somebody else would necessarily get to see. And from that, we might learn, we might bear witness to resilience, we might learn about coping. When we work with bereavement in particular, we learn about love and we learn about connection, and we learn about how that love and connection transcends somebody's death and is integrated into the lives of the people that they leave behind. And that is an incredible privilege. So there are many drawbacks, as we all know, for exposure to trauma and the way that it shows up and impacts our working lives and our personal lives. But it's also important that when we're thinking about vicarious trauma, that we don't miss that capacity to recognise vicarious resilience as well, and the privilege of doing this work. So the last couple of slides, I've got some resources if anybody wants to look at thinking about toolkits for developing vicarious trauma-informed organisations. There is also, it's an American tool, but there is also a tool that organisations can use to assess capacity to address employee work-related exposure to trauma. There's some resources from the Dare to Lead Hub from Brené Brown, who talks about strengthening leadership capacity. And there is also some further training via Thrive London, which is funded by the London Mayor's Office, which is focused specifically on developing trauma-informed practice and does cover vicarious trauma and also looking at it, engaging with bereaved families following a traumatic material. Following a traumatic bereavement. All of the material is free to access via the link. So if anyone has interest in the topic beyond today, please feel free to access that. I'll also pop my contact details in the chat as well. So if anybody wants to email me afterwards, ask any more questions or ask questions now, you'd be very welcome to. Thank you.